Good morning, good afternoon, and good evening, everybody. Thank you very much for joining this session today. It's been a wonderful 3 days already. And if you require a translation, please activate your auto-translated captions under CC. And this slide is showing you how to do that. Today's session is going to be about solutions. As you have seen in the last 3 days, we have had a very good introduction to the hidden global crisis that burns cause. Today, we are going to seek some solutions to transform the burns from a hidden global health crisis into a visible one. So how can we make people understand what the problem is? Do we really know what the problem is? Or are we banking on a major incident to happen and then we jump on the bandwagon and say there is a big problem? Well, what is the magnitude of the problem? I think these are questions that health professionals, carers need to grapple on and make it our duty to inform people. Lack of data around burn injuries, around the outcomes, and around the care provided presents a missed opportunity for developing targeted policies for prevention, burn care, and survivorship. So today you are going to learn more about why data is very, very important. And we are very privileged to have Dr. Orlando Flores from CONACYM, who is going to talk to us about how they developed their registry across Latin America. And we are then going to have Professor Vinita Puri from India, from Mumbai, who is going to talk about her single center data collection over many years and how that has helped the epidemiological trends of burn injuries that are admitted to her institute. And we are then going to hear from Bronwyn Griffin from the ANSBA and Brands Registry, which has been going on for a long time. And she's going to talk to us about the contributions of this registry that is going to help prevent burn injury, or that has already helped to identify the magnitude of the problem and care provided in Australia and New Zealand. So you're going to have a range of presentations. We are going to learn and share our knowledge. And the idea is that those who do not have something in place will be inspired to start something. And at the same time, those who have some, we can share our registries around the world and help global health crises arising from burns to become a visible problem. So at the end, I would like you all, while during the course of the presentations, please do add your questions to the Q&A. We will try to come to the questions and address them as far as we can today, but we will be able to help answer those in the fullness of time as well. I am going to start off with Dr. Orlando Flores from CONACYM, and he is going to take over from me now. Thank you.
Thank you very much, Mamta. I'm going to share my presentation. Good morning, good afternoon, good evening, everyone. I hope you are seeing my screen now. Is that okay? Could you please let me know it's working? Thank you very much. Okay, as Mamta said, my name is Orlando Flores, and I am the director of the Registro Latinoamericano de Quemaduras project, and I also work for CONACYM in Chile. And I'm very proud to be launching actually this project with the whole burn community today. This is our logo. This is how the branding of RELAC looks like. And I have no conflict of interest to declare, but I would like to share with you that this talk is actually not about the importance of having data, because we have know that before. Mamta has stressed about that point. Is also not focused on how we can improve our practice in burn prevention, care, rehabilitation by using data, it is really about collaboration. What I'm going to tell you about is how we build this project based in collaboration. And I'm just going to share with you how this we get to know this paper published in injury prevention, saying that the incidence of burns was decreasing across the world, but increasing in Southern Latin America. And we were questioning if the data was good. And we find out that the data that we have in our country, in Chile, was not really good. And we were also thinking whether we need a burn data registry for all Latin America. And we concluded that, yes, we needed that. But there's also some doubts in our team regarding the capability that we have to run such a big project. And we thought that, no, we are not capable to do so. But well, we started early 2021 with this idea. As I told you, I work in Coanicam. Coanicam is a solid institution in Latin America, has a lot of contacts in Latin America, and we got this leader in Coanicam. There is a person that can convince you and instigate change. And he was very convinced about doing this for all Latin America. So then, when we start thinking about this, we decided that we should build a team. So we call our friends distributed in burns units all over Latin America to ask them whether we have the same problem and whether they were willing to solve the problem together. So we bring friends from Argentina, from Costa Rica, from Guatemala, from El Salvador, from Peru, trying to check whether we can think on a project together. But even when we were all convinced in Latin America that this was a strong project to pursue, we were still not solid enough to try to build this project. And then I remember on my times living in Australia, and I asked my very good friend, Griffin, that is going to be talking to you in a couple of minutes. And I asked for help just for knowing how we can actually build a burn registry. And she invited a icon singer as well. We got quite a few meetings, and they helped us to better understand the problem, how we should build a registry, provide us guidance, and provide us some documents that help us to start. So the beginning of RELAC, the Latin American Burn Registry, is based on the help that brands gave to us. And then we thought that it is pretty good that we are a group of people motivated that we wanted to run this project. And we also have technical support from brands, but we wanted some academic support in Latin America as well. So we invited a university, a public health school in the Catholic University in Chile, and they were willing also to provide us some help. And then we talked to the Pan American Health Organization, which is the branch of the World Health Organization in the Americas. And they were also interested in the project, and they're willing to help us to have a kind of a political view, because we knew from our experience that change sometimes requires some political change as well. And that is something that was resonating in our minds, and we wanted this to have covered that area as well. So we invited them to the project, and they were willing to help us. After having all this small step to provide a solid foundation to our project, we decided to bring some people to give us some governance, because we wanted that our decisions were strategic, and we didn't want to decide everything here in Chile. So we bring the leaders of this burns unit from 6 different countries, plus a representative from the Pan American Health Organization and an academic from the Public Health School in the Catholic University. And we formed the steering committee for RELAC, and they are actually deciding, providing some strategic thinking to see how we can develop this project further in the future. And then when we had this kind of organization, we thought, okay, we are going to need to write a data dictionary to select the variables that we are going to start with, to conceptualize the variables, to work a little bit on that sense. And again, we asked for help in brands. They actually were very generous, and they offer us their dictionary, so we cannot start from scratch, but adapt the data dictionary from brands to our needs. And we did that with a group of academic clinicians, professionals that help us also to give shape to what RELAC is nowadays. So this is actually a lot of collaboration going on those days. That was probably a year and a half ago. So at the end of the day, we wrote the data dictionary. We included more than 70 variables. We conceptualized each variable. We provide registry guidelines for each of the variables we included. And we were kind of ready to start thinking on how are we going to input the data in the registry. Because obviously we didn't want to do it in an Excel sheet and so on. And as you all know, having a platform for doing so is very, very, very expensive. So we start applying for funding, which all of us do very frequently. But I'm just going to tell you that a year ago, a little bit more than a year ago, we received the email that any project lead want to have in this inbox, saying that we got the money that we need to build the platform by a foundation in the USA, the David and Lucille Packard Foundation, and they were willing to pay for the development of our platform. And this was a very good news. We work together again to build the platform, and this is how RELAC platform looks like nowadays. We just finished building our platform. We think it is a beautiful tool for data input, and that will promote collaboration across our burn centers in Latin America. And we are going to use the first semester of 2025 to do the piloting of the platform in all our centers. So finally, for using this platform, we also thought at that moment that we need to have some training together, and that was something that we really want to do face-to-face instead of using Zoom. We all know that Zoom has some advantages, but also we needed to talk to each other, to be trained together on how to use the platform, to standardize our process, because we will be registering data in the same registry, and we are from different countries with different cultures, with these slightly different language uses. So we asked again for funding to our government, to the Chilean government, through the Agency for International Cooperation, and they fund our training sessions. Nowadays, and in the room where I'm right now talking to you, there's the whole steering committee of RELAC coming from different parts of Latin America, and we were able to fund this effort by asking for funding to the government as well. So we have, as you know, we have knocked many doors to make this effort possible. So this is what we have been doing the last 3 days. Unfortunately, I couldn't get into the other World Burns Week sessions, but we have been working with the World Burns Week on our minds, trying to share what we know, trying to prepare ourselves to start collecting data next year. And it has been really a beautiful time for all of us. So just a couple of ideas as a conclusion. What we have learned during all this time is it is very important to not be afraid to say I don't know how to do something. It is perfectly okay if you are not capable to do something by yourself. As long as the project is good, is motivated, it is important, it's meaningful for a group of people, you will at some point get someone to help you technically in terms of financial resources. You will get the help that you need. And I think that the key for the success is just surround yourself with good people that is interested in the same stuff that you are interested in, and simply never give up. If the project is good enough, you just need to push. And at some point, there will be an open door for you, and you will make this dream a reality. So thank you very much for having me in this session. This is a picture we took just last Tuesday in the last meeting of our steering committee, and I have done this presentation not as myself, as Orlando, but presented on behalf of the whole steering committee of RELAC. Thank you very much.
Right. Thanks very much, everybody, Orlando. And I think we'll move on to Professor Vinita Puri for her presentation. So, Vinita, if you would like to take over, please. Orlando, you've unshared. Yes, thank you.
Thank you, Mamta. So that was amazing, Orlando. Congratulations to you and the whole team. Wonderful. And I hope that, everything goes great. So, as told earlier by Mamta, I'm going to be basically presenting the trends of the last 25 years. And so it is going to focus on the epidemiological results. And this is from the data that we have been collecting in our department at St. GS Medical College and KEM Hospital. Our hospital is a tertiary care center. Basically, it's a university hospital. And we are a plastic surgery department that also has an attached burn unit. So why did we start this data collection? It was basically just to understand the numbers that we have. Because as the numbers go by, if we don't keep our data, then we wouldn't know over a period of time as to what are the numbers that we are dealing with, are some of the works that we are doing towards prevention and other activities, whether they are of any help at all. We also wanted to know the spectrum of burn cases that present to our unit. And of course, analyze all that and analyze the risk factors. Frankly, everything that we did was more in terms of risk factors, looking towards the prevention activities that we could do. So now this is just an introduction to our burn unit. We are a public hospital, so it's not a corporate hospital. It's a very basic burn unit. I have 12 beds. And this unit was started somewhere in the late 1970s or 1980 by the earlier head of department. And at that time, they had requested to keep in only the adult females. So now this is really a reflection of the society as it was at that time, when there used to be way more women who were getting burned than men. The male burns were mostly only burns that were happening in industries, whereas women were, there was a social element to this burns in women. As our numbers, as you'll get to know, as our numbers reduce somewhere in 2013, I put in a request to the administration that a few of our beds were remaining empty. So we started also taking in pediatric patients. So here you see a ward, and you will see that, though I don't have any cubicles or anything like that, we do use our ventilators and multiparas in the same open space. Even the therapy is given in the same space with to the best of our ability. We do make a lot of stuff in-house. And like, for example, if you see this art wall is just a plastic sheet which is stuck on the wall. And that, so we try and give comprehensive care in the space that's available to us. Data that I will be presenting to you, as I said, is of the last 25 years. So I have collated the data into two parts. One is from 1999 to 2011, that is 12 years, and then the last 10 years. So the variables, there are a lot of variables that we have been recording over these years, and our data surveillance sheet has changed twice, but most of the data that we collect is the same. So what you're seeing here is a scanned copy of the really old data sheet, the proforma that we used to have. And you'll see that this is basically being typed, and we used to photocopy this, have these, and physically, write all the details. And you will see that all the person had to do was tick as was needed. And this is the newer data sheet that we are using. We continue to use it in a physical format, but all of these are scanned and kept for us. So let me now present to you the results. So in the first 12 years that I'm talking about, you can see that the number of cases are much more. It's almost 1,700 over 12 years. Whereas in the last 10 years, we have just 900 cases. You can see that the number of cases have reduced to almost half, or a little more than half as compared to earlier. So now when you look at the trend, the one that you see in blue, those are the women. So somewhere from 2014 and 15, we started taking in also children. As you can see that the number of cases started reducing. There's just one spike in 2005. Otherwise, earlier, prior to 1999, in fact, we used to, as a routine, have anywhere between 200 to 250 cases. And after that, the numbers started reducing. Here we have this dip because we were under renovation, so our ward strength had reduced to half. And after that, you will see that women burns have gone down so much that if you compare 1999, where we have almost 225 women who were admitted, in 2024, or I should say last year, we had barely 30 adult women who were admitted. So you can see that there's a big change, and you can see how this graph has come down. Looking at the percentage total body surface area burned, that too has changed drastically. Look at 1999, and you will see that the average total body surface area burnt of the women who were getting admitted to us was 70% body surface area burnt, and that's a really huge number. The next year itself, there was a sudden drastic drop, and we started getting slightly lesser, but not drastically less. So this was also about 50% of the body surface area burned. This is the average. And somewhere from 2016, suddenly you see a dip. This could be because of two reasons. One is that the number of women itself getting burnt were lesser. Secondly, we started taking in pediatric burns. Those were scads, and the percentage of burns was lesser. And hence you see that now the average total body surface area burned is barely 25%. Looking at the mortality, that obviously is going to reflect according to the the severity of the burn that we are receiving. And since the severity of burns that we are receiving has gone down so much, even the mortality rates have improved. And you can see this in this combined chart that I have made. The mortality is reflective of the total of the percentage burn, that is the kind of patients we are seeing. Let's look at the age. Now, when you look at the age of the patients, you see that a very large number of patients, a very large number, we have 1,100 patients almost of young women, 15 to 35 years old, who were admitted in that first 12-year period, whereas we have just 300 such women who were admitted in the last 10 years. So again, this shows that the number of women who are getting burnt has reduced drastically. When you look at the cause of the burns, flame burns in adults continues to be the maximum reason for burn. But in this last 10-year period, we have a very large number of scalds because most of the children who get admitted are of scald burns. And if you saw the data, it's almost half now of the 100 patients who get admitted. Half of them are women and half of them are children approximately. So in the early period, when you're looking at this, the 1999 to 2011 data, you will see that 12% was suicidal burns. I also have a publication on this where I said that, this is a retrospective data, but when you actually talk to the women, probably there are some places where the suicidal burns were much more. So suicides using kerosene as an agent to burn yourself was much higher earlier, whereas now when you see accidental burns have gone up in terms of percentage, but again, this is reflective of the fact that we are taking in a lot of pediatric burns. How was the fire extinguished? This data kind of, it's a bit, I'm not able to understand why, but here from what I see is that use of water to extinguish the fire seems to have reduced, and the people seem to be using a blanket more, which is not the right thing to do. Probably we need to again work towards educating the people about the fact that it would be better to use to use water to extinguish the fire. In terms of place of injury, nothing has changed. Earlier too, most of these injuries, 90%, over 90% were happening at home, and they continue to do so even now. So over the last 25 years, there is no change in the place of injury of the burn injury. When you look at the houses that the people are living in, this kind of doesn't make adequate sense because it looks like earlier they were living in better houses. It could also, three things. It could be a reflection of the fact that there are more people living in slums, or it could also be a reflection of the fact that from when I look at our data from 2013 onwards, we have a lot of cases which are coming as referral cases. They come to us 2-3 days later from outside Bombay and from the villages and smaller towns. So that could be the reason why the housing has changed. Looking at the place of cooking, that this data looks good. Earlier, 70% of the women who were coming to us had got burned, and they were using the floor for cooking and did not have a platform. And over the years, you can see that the use of platform has increased. The cooking appliance that was used again, earlier we had a good number using the kerosene stove, whereas you see that the number of people using a LPG, that is liquid petroleum gas, has increased quite a bit in the 2015, 2014, and the number of people using the wood fire has reduced. So this is the kind of thing that happens, place of cooking when it's on the floor. Women are often wearing loose clothes, and they may get burns, and this is the kind of stove that is used. Occasionally, there is a kerosene spill, or some people say it's a stove burst, because they need to pump the stove when they use it, but it is often just a faulty appliance which causes a problem. As compared to earlier times, I think the number of patients going to better centers, secondary centers, and tertiary centers has increased over the years. So if I look at the summary of the results, I see that there are lesser number of women who are getting burned. The percentage of burn is much lower in the last decade. Mortality has reduced. And the one thing that has remained steady is that more than 90% of patients continue to be getting burnt at home. And most of them are kitchen accidents for women. So I think a lot more effort has to be put towards prevention at that end. And the good part is that floor level cooking has come down from 70% to 50%. So why is it that that there is such a drastic change between 1999, as you see? Here we had such a large number of patients, almost 200 to 250 patients. And here we have much lesser people getting burned. So I can think of 3 reasons, and I'm going to share them with you. One is there is something called a ration card. So ration card is a card that is owned by every citizen of the country. And earlier there used to be a single ration card. And when they said ration, basically there was um, cheaper rice, wheat, and items which were available by showing the ration card. And there were ration shops where people could pick these up. In 1999, the government of our state decided to give ration, decided to give the cheaper stuff only to the people who are poorer. So though ration card is also, though the people who are richer didn't really use their ration card and go and pick up, the cheaper food items and kerosene, government decided that they would then change the color of the ration card. So people with the white ration card or the orange ration card stopped getting kerosene. And kerosene is the one which was used as a fuel for the stove. And I think that that is one place which made a lot of difference, and the higher percentages of burns reduced drastically after the use of kerosene reduced in society. There is another scheme which was started by the government. It was actually proposed in December 1995. And this is something called a slum rehabilitation scheme. I think most people know that Mumbai has a massive influx of migrants from all over the country. And there is a large number of slums in our city. In 1995, it was proposed that there would be a public-private partnership where the government would invite developers to make buildings at their cost. And this would be at the place where the slum is situated. The government would also give some extra land to these developers so that they could also build a building which they could then sell apartments there. But what was good about this is that the people living in slums actually got to live in an apartment, and hence they had a apartment which had a bedroom, a kitchen, a bathroom, and a toilet at no cost. And I think what this did is that that helped people move from floor cooking to a platform cooking. And finally, I think one of the schemes which has really reduced burns, which are because of stove and kerosene, has been this scheme, which started in 2016. It's called the Ujjwala scheme, and it was launched by our Prime Minister. This was introduced to provide liquid petroleum gas connections to women which are below poverty line. And the main objective of this, in fact, even reduction of kerosene earlier, the main objective was to make clean cooking fuel available, and LPG is a very clean cooking fuel. And though the initial target was to provide it to just 5 crore connections, but later the targets were increased more because the targets were achieved earlier than expected. So when we look at this Ujjwala scheme and the penetration of LPG now in the country, I think in 2016, probably when it started, it was barely maybe 18 to 20% of people in the country were using LPG, whereas today it has gone up to 70%. So I think all these three must have probably made a difference in the number of women getting burnt in the country, in our state. So these are the points. At this point, 1999 is when suddenly the amount of kerosene that was being provided had reduced. The slum rehab scheme, though it was proposed in 1995, by the time the buildings started getting built, I think the apartments started getting handed over somewhere in 2003, 4, 5, 6, somewhere there. And I think there you see this massive dip that happens after that. Once the LPG scheme starts, the dip is much more. These are just my thoughts, and also probably there could also be some changes in the sense that more hospitals are coming up. So maybe there is a little bit more distribution of patients. I say this because finally we do have a selection bias because we are taking in only adult females. And hence it is not a true reflection of any absolute numbers or incidents that is happening in society. But I think if we continue this kind of data collection, and each center, even though we don't have a registry as yet in the country, the government is making its efforts towards it. I think if each center continues its data collection and we collate data from many centers, we can probably provide good information on the reason for the burn management and reasons for any positive trends as we see in our case. And we can also extrapolate data that is happening in our state, and we can identify infrastructure and human resources that are needed for good patient care. I think long-term data collection also, and when we publish this data, these kind of data, it also helps to increase the visibility of the burn burden and also helps direct and formulate policies. Thank you so much.
Thank you, Professor Puri. That was a brilliant presentation, and we already have a few questions which we will address at the end of the session. May I please ask Bronwyn Griffin from Australia to join us, please? Thank you very much.
Can you hear me okay? Great. Good morning, good day, good evening, good night. Nice to be here, and thanks so much for inviting me to come and speak to you today. Yes, my name's Bronwyn Griffin, and I'm from the Queensland Children's Hospital and Griffith University in Brisbane, Australia. I'm also the chair of the Australia and New Zealand Burns Association Research Committee. So I'm very happy to talk to you today about the registry contributions to burn prevention and care throughout Australia and New Zealand. For those of you who don't know, the ANZBAR is a binational burns association between Australia and New Zealand. And these are a few of our burn centres that are a mixture of paediatric or all adult or mixed departments across Australia and New Zealand. And as you can see, they're all scattered around the periphery of our country, all girt by sea in Australia and New Zealand. And that's largely because in the middle of our country is a very arid area. So our population tends to be really condensed around the coastline. And in New Zealand, they're not so arid, but they have these lovely mountains, Alps in the south of their South Island. And just for a bit of scale, that sparsity of land in between our burn centres is far and wide in between. So it makes for certain considerations of burn care and transfer really important when we think of the scale in the different spaces of which we work. And that's America, and the previous one was Europe. Sorry, I couldn't find any for South America, Orlando, just to fly your flag. So it does provide for certain lifestyle options, and some of these are wonderful areas for families and friends to gather around. And but this does also pose a danger for many of us as well. When we think about the registry that we have in Australia, we first and foremost, like many of you have mentioned already, think about the power of prevention that we have within that data. Today, I'm going to be just showing you a very small sample of papers. It will just scratch the surface of a number of the papers and projects that have been led. So I invite you to have a look at the brands, the Burns Registry of Australia and New Zealand. They have a website through Monash University where the registry is stored to have a look at the full spectrum. So unfortunately, I'm not the chair of the brands, and they are, as Orlando already alluded to, a very helpful community of people. So here's a couple of papers. So one of the examples is a review of petrol burns in Australia and New Zealand. We've also looked at sunburn injuries. We are a sunburnt country, and this was looking at some patterns of injury of sunburn and the severity of the heat of the sun that we experience, and friction burns, also looking at very different mechanisms and how we can target prevention messages to help address those injuries. If we look at the review of petrol burns, for example, that paper highlighted that the majority of patients were very young in terms of young males, young adult males. And these burns were happening in times of holiday periods, quite condensed in those longer weekends or holiday times, but also importantly happening in those non-metropolitan centres. So there are deeper burns, bigger burns, but also happening further away from our burn centres. Much like this picture here, which is my son, who is turning into a young man, surrounded by other young men and perhaps not making sensible decisions. And just before this picture was taken, you can see here that there was a can of petrol involved in the ignition of this particular fire. So I'm not perfect myself and the people I surround myself with. But in terms of this paper and understanding some of the patterns of this injury and where they were happening, the lead for this paper, Dr. Stephen Goldie from the Alfred Hospital in Melbourne, made sure that this message was being distributed to relevant media. So there were multiple interviews with radio and television and papers, so that the message could be spread further and beyond a paper with the data that's been analysed beautifully from a research perspective. But importantly, we want this message to reach people to hopefully prevent these injuries from occurring. And as I mentioned, these sort of targeted messages should be going out to the areas in which they are needed the most. When we look at our data to influence first aid, it's the next line of prevention, I guess, is stopping the progression of the depth of the burn of the injury. And this is what burn first aid can certainly offer, the 20 minutes of cool running water, which is certainly recommended by Australia and New Zealand Burns Association as the first line of first aid. And we've certainly used the amazing data from within brands to be able to address what the power of that intervention has on the clinical outcomes of patients. So Fiona Wood and her team led this with the adult large cohort study, and myself and my team did a similar paper in pediatrics and looking at the clinical outcome benefits for patients who've received 20 minutes of cool running water. And just some of those in the pediatric population was looking at the odds ratio of skin grafting requirements was reduced significantly with 20 minutes of cool running water. We were able to prove that patients who'd had 20 minutes of cool running water had a reduced risk of a full thickness burn injury and a reduced risk of requiring an admission. Also, patients who had 20 minutes of cool running water had much faster time to reepithelialization and much less need for operating room time. So we're able to prove all of those things, which is a really powerful tool to be able to do all through registry data. We also looked at, used the registry data to look at then where some of our barriers were. Not all patients are getting first aid. And so we want to better understand how we can address that gap in knowledge or practice within the data that we have. And so with the registry, we were able to identify that certainly our youngest patients, our older patients, patients living in rural and remote areas, and what healthcare providers required that additional education. And so that's a real opportunity for us to, again, target in on where that gap in practice is. And as a result, I've been fortunate to receive some funding to address the rural and remote area. And this is my state of Queensland, which is in the northeastern state of Australia. It's not the whole country, but it's still a very large area. And just for example, where this little car is situated on our left to Brisbane, where we are in the southeast corner, is a 14-hour drive. So it's still a really long way in between each of these areas, with not very much in between except a lot of kangaroos and emus. This is the very tip of Australia, which is called the Torres and Cape, and this is one of their hospitals, which we'll be addressing and understanding what their needs are and what their barriers are, and if we can address things more specifically for their needs. And the other thing that we acknowledge in Australia is the traditional custodians of our land, the First Nations people. And I think it's certainly very important. I've been having conversations with people from rural and remote areas and First Nations people to understand the context in which they live and how we can better help them address them face to face also. Internationally, we've been very fortunate to receive some US Department of Defense funding, and we're now using our findings from our Australian registry burns data to influence the burns first aid practice in America, and we're working with the Sacramento Fire Department in California. Hello to all the Californian people joining us, and UC Davis Emergency Department, as well as the UC Davis Firefighters Burns Institute, and over the road at Shriners Hospital for Children as well, to make sure that when translating this knowledge and implementing it into a new health space, that we're showing that the effectiveness is there and the implementation is possible also. In terms of clinical practice, there's lots of papers on varying types of practice, but here's 2 papers, for example, where we've a team from the Alfred has looked at the burns registry to look at early burned wound excision within 24 hours. And certainly my team have looked at early non-excisional burned wound debridement in the first 24 hours and how that impacts the outcomes for patients. In the adult early excision paper, they were able to identify that for a category of patients with 20 to 29% TBSA, when they had early excision, they had a mean length of ICU stay reduced, and they had a mean mechanical ventilator hours reduced time significantly. And certainly in our pediatric population, we looked at non-excisional early debridement in the operating room, less than 24 hours, and just in a cohort of TBSA 5% and above. And we were able to demonstrate that the time to reepithelialization was reduced significantly, and the odds of requiring a skin graft were also reduced significantly, all through registry data. So I would say for registry data that the research tool belt is absolutely, the registry is the power drill. It is so powerful and such a big catalyst for change. But I think also with that, it is not the only tool. It is not the panacea of solutions. It has to be used in conjunction with really good quality research, skills, governance, and people and communication. I think one important thing with registry data is that there is a responsibility to transition the data and the analysis and the findings into meaningful change, and whether that's prevention or practice or new knowledge, it's a really strong thing. It's often, as you mentioned, Orlando, a really hard thing to do. It's not always easy to know how to make change in society or politically, but it is our responsibility to at least try, and sometimes and many times fail. So yes, in summary, I think it's powerful to determine risk and outcome variances amongst other things. I certainly encourage interdisciplinary partnerships from within our burns organisation. So our burns registry team speaks very closely to our ANZBAR prevention committee and to our nursing committees and allied health committees. So there is a lot of cross pollination between our groups, but also with other professional groups, with groups from emergency departments and political departments, so that we are making an impact, and certainly going beyond publishing and being responsible with that data that we find. So thank you very much for your time.
Thanks very much, Bron, and thank you very much, Orlando, Vinita, and Bron. It has been a fantastic session. And in the chat, I have asked if anybody is collecting any data to put that down. It would be wonderful to be able to share our knowledge. And if anybody wishes to contact any one of us for support or collaborate, please put that down in the chat as well. I would like to welcome Tom Potokar to join the panel now, and we will commence our discussion. Whilst Tom is unmuting to start off the discussion, Tom, are you ready? Yep, there you go. Tom, I will pass over to you to start the discussion, and we have 3 questions, one of which Vinita has already responded to, but Tom can ask start the discussion, please.
Yeah, thanks very much, Mamta. And apologies for missing the first bit of your presentation, Orlando. I think these were all really fantastic presentations and highlight all the kind of key things about data. And I guess that the first thing is always, what is the purpose? And I think that's something that needs to be, when people are considering collecting data, because there's lots of different reasons to collect data. There's to impact on prevention, right down to collecting data that can help you implement a change to improve infection control or whatever. So they're the registries that we're talking about, and then all sorts of other data. So I think it's really important, and I think you've highlighted in each of those presentations why you're collecting the data. But anyone who's starting, I would suggest kind of using the 5 whys approach to, you know, if you say, well, we're collecting it because we want to look at the number of adult burn injuries we get. Okay, why? You know, oh, because to see if they're caused by X or Y. Okay, why? And really focus it down. I think as well that, you know, you've all mentioned some of the difficulties in collecting this data, and it's so important that the data is reliable, because if it's unreliable data, of course, it doesn't really serve any purpose. And I think the analysis, again, all of you really presented so well the analysis, because the data is only valuable if it's analyzed properly. And that requires this kind of robust academic approach, and also the kind of, there's a certain way of looking at the data, because, and I think, Vinita, you showed it in your presentation very well, but as all of you did. But, you know, for example, sometimes it can look as if things are getting worse, but actually that's not, you know, a good example would be mortality rates going up in a burn service. That doesn't necessarily equate to the burn service getting worse. It can equate to the burn service getting better, and therefore receiving more severe patients who are more likely to die. So, you know, the analysis is so important, and I think you all demonstrated a really good analysis of the data that you're getting. And then, you know, Bronwyn, at the end, you mentioned, you know, which is so important, this data, okay, if we have the data, but it has to lead to change. If it doesn't lead to any change, then it's not really serving its purpose. So all those points need to be thought of before entering, you know, some sort of registry. You know, okay, well, what's the end result of this? What do we want to try and change? And whether that's prevention, treatment, whatever, but to demonstrate that it leads to change, which, you know, which I think you have been doing. And then just on the implementation side, I think, you know, so one of the questions was, you know, and I see some of the questions and think, you know, how to set up these databases, because they're setting them up and then they're sustaining them, and those are 2 separate issues, and I think they're both really important. And so understanding some of the concepts of implementation science, basically, and understanding before starting, okay, what are the barriers and facilitators to setting up any sort of registry, looking at all the steps along the way, who's going to do what, and often things don't work because of the you know, the most minor issue, because there was a power cut, the person didn't have a pen, the patient left before X, Y, or Z. So it's kind of process mapping everything along the way to try and make sure all the data is captured, and to looking, you know, using one of them as the consolidated framework for implementation research, for example, which looks at what is the intervention, what is the inner sort of local setting, the broader outer setting, what's the process, and what are the characteristics of the individuals involved in that process. And that's quite a helpful way for looking before you try and implement something. So I'm going to just, that was a sort of summary. I think there are some specific questions which you probably got the key to, Mamta, but I would congratulate you all, because I think they really demonstrated, as you said, the power of you know, data collection and how it can lead to change. And, you know, if we don't know the results of what we're doing, we don't know whether we're getting any better or any worse. So yeah, I think congratulations to all of you for some really good examples.
Yep, thanks very much. I think the first question from Sophia was, how will you be sure that people invest their time for registering their cases? Who is the administrator? That was for Orlando. And I think Tom kind of alluded to that. So Orlando, would you like to respond to that?
Of course. Well, I think that this is a challenge actually for all the people that is starting with a new registry. We want the more complete data that we can have, and also we need to be sure that the standard is also good. Otherwise, as Tom has pointed out, the internal validity of whatever we do is going to be weak. What we are planning to do, and that is why this started by calling some colleagues/friends, is that we build a strong community to begin with this. So each of the people that is with me in this very room is people that is committed to this registry, and is people that has brought with them some of the people that will be doing the input of the data in our system. So first, I think that we need to convince them that this is very, very important, and that this really can change the landscape of burns in Latin America. Second, I think that as long as we have some financial resources, it's very good to provide some sort of incentive as well. We are trying to do so. At the moment, we have some money at least for providing such an incentive for the beginning. But I think that the key thing is to bring people that is motivated and trying to establish a system, a governance system that kind of audit what we are doing. And this is something that we actually learned from Bron and Yvonne when we start talking about this. We talk a lot about the challenges and barriers and where a project like this can fail. I'm not completely sure what is going to happen in the future, but I have some ideas on how we can avoid some of those problems. I think that we can check next year how it goes for us. Thank you.
Thanks, Orlando. Bron, do you want to come in and share some knowledge?
Yeah, I think governance is something that needs to keep being addressed, Orlando. There's so many changing themes and capabilities, and you know, the more sophisticated registries now are looking at registry randomized control trials. So, you know, does our current system have the capacity to be able to use that function of registry randomized control trials? And so I think there's always room of coming back to those motivated core of motivated people who will keep the momentum of the registry current and relevant. As Tom was talking to, keeping the why at the center of the registry as well is really important. It motivates people to keep supporting when it's really hard and you feel like you're failing. It's really tough, and even in our developed registry, we still have challenges of funding and completeness of data. But it is worth trying for, I think, and having that a really strong governance is something that will not prevent failures from happening, but it will certainly keep the conversation transparent and open and moving to adapt to the times and the context in which all of your different centres will be working. It sounds like you've done an amazing job, so well done for getting as far as you have.
Thank you very much, Bron. Vinita, would you like to share your views? You'll need to unmute.
So our registry is very local. That is, we have our own, but I think our country is we are making an effort. In fact, the WHO is also involved in between, but it's not happening. And I wish it does, because that is going to actually let us know. There are two things. One is that our number of women burns are reducing, but positively there are burns because of other reasons which are increasing. For example, we have the LPG problem itself. And when that happens, when there's an LPG cylinder blast, you have way more patients who come in at one time. The whole families are, changing. So maybe that will help us know exactly what's happening. And I know that in a center like ours, we have much lesser patients as compared to when you go to, for example, the north, then you go to Delhi. Hospitals in Delhi are dealing with way more patients than our hospitals are dealing with. I accept that registry is important, and I really congratulate Orlando and the Latin American Society for having come up and having their registry. As a society, we are not able to do that because it's not just us who treat the burns, and burns are being treated across the country, smaller places too. So I think unless and until the government makes a registry, and makes it mandatory to, as I say, inform them, like maternal mortality. There are some things which are being, you have to inform the government. There is malaria, or there is dengue, or there is leptospirosis. It essentially has to be informed to the government. So there is a registry for that. It's not yet happening in burns, but I'm hopeful that it will happen, and then it will positively help, to come up with government and how do I say, maybe with broader prevention activities.
Sorry. Thanks very much, Vinita. Final few words from Tom before we end our session. It has been a great pleasure to chair this session with excellent presentations. So Tom, I think you are the right person to end this session with your knowledge of global burn registries.
I'm not sure about that, but yes, thank you. Well, I agree. I think this is such an important session to have in the week, and as I say, these 3 examples today, I hope will inspire people. What can be achieved, and I think it's important to think. We know. I mean, I was involved, as I'm sure many were, with the global burn registry, the WHO one, which, to be honest, I'll be brutally honest about it. It started with really good intentions, but it hasn't been as successful as we'd all liked. And that is in part, I think, because the implementation of it wasn't really thought through at the beginning. It was more, let's get the registry, and less focus on, but how's it actually going to work? And maybe a bit too much reliant on too few people. But I think in terms of the data, from every level, from the individual unit level up to regional, national, and global, data collection is really important. And that even at that very local level, it can have real impact on outcomes and on quality of care for patients. So, I think that's in some ways, that's the way to start, is to look at the local data and how that can actually impact on the quality of care delivered to the individuals that come to your unit, whilst bearing in mind that we should all be trying to work towards a more globalized system and somehow linking this data together so that we can address the bigger issues. And it's clear that people are working very hard across the globe in all sorts of different areas and ways to do that. So thank you very much for all your tremendous efforts and the great presentations, and I hope that's inspired other people to start to do similar work.
Thank you very much. And on that note, I will hand back to Natalie, and thanks very much, Natalie. Thank you, everybody, for joining us as well.
Thank you everyone for joining today, and I'll just leave the schedule for, this is the summary of our week so far, and we hope everyone will join tomorrow for our next session of World Burns Week focused on commitments. This is our final session of the week. Thank you again for joining.